My name is Adele White. I am a project manager at Healthcare Education and Training. And today we're here to talk about trauma-informed care in pediatrics with Dr. Schrader. I'll let her introduce herself later. But we're going to go through a couple of housekeeping things in a minute. But I also want to turn things over for a second to my colleague, Kara, so she can introduce herself. Go ahead, Kara.
Okay. Hi, everyone. If we haven't met yet, my name is Kara Berg-Ronick. I am the Director of Health Strategy and Advancement here at HCET, and also am proud to direct the Midwest Trauma Informed Training Center, which is part of what brings you this series on trauma informed care. The Midwest Trauma Informed Training Center was born about 2.5 years ago out of sort of a recognition that trauma informed care is becoming a popular kind of concept and a buzzword. And while lots and lots of good work was happening across our state and across the Midwest and across the country, that it was really pretty siloed and not super well operationalized. So we wanted to sort of step in and help bring all that to the forefront, help provide training and resources to help you in your work. Make trauma informed care something that is doable, something that's more than a concept, but really can come through in action and be the standard of care throughout the Midwest. So, thank you so much for joining us. Thanks for the work that you do and your interest in this really important topic. Um, Spoiler, I had the pleasure of presenting with Dr. Schrader years ago, actually. And she's brilliant, and we're really thrilled to bring her to you now. So I'll turn it back over. Thanks.
And then, Dr. Schrader, if you just wouldn't mind clicking, I'll just make sure we didn't miss anything. I mean, some of you have met us before. This is our last of 6 sessions, but as Kara mentioned, Healthcare Education and Training is a nonprofit that focuses on sexual and reproductive health training for people like you who are on the ground doing the work, public health people, clinicians, staff that work at care centers. So we're here to support you by bringing you people like Dr. Schrader to give some discussion and education around lots of topics and specific to trauma-informed care today. So please click to the next one. And then Kara talked about our Midwest Trauma-Informed Training Center. I bet for a lot of you, this isn't your first webinar, but we are so grateful that you're spending time with us to discuss this really important topic. Next, please. With this webinar, what will make it most easy for all of you is if you use the Q&A button at the bottom to submit questions anytime through the session rather than the chat. We just don't want questions to get lost in the chat. So if you would please use the Q&A option at the bottom, that would be super helpful to us. And then submit them anytime. You could submit them anonymously if you like, and we will go through those at the end. Thank you so much. Please, next. And then if you would like a transcript or subtitles, down at the bottom, you'll see a little button that says CC. Just click that and you'll see some options to see closed captions transcript for what we're saying. Next, please. If you have any technical difficulties during this time, use the email that you see at the bottom of the slide. It's updates@hcet.org. My colleague Jen is managing that, so she will assist you as best she can if you experience any technical difficulties during this. So, yeah, updates@hcet.org. Oh, you're good. You're good. And we'll send an eval at the end. We would love to hear what you guys think, but I'll talk about that at the end as well. And then if you want to see what else we have to offer, follow us. We do lots of trauma-informed care trainings on many different topics. You can look for us on Facebook, Instagram. We're hcet.org on all of them, or our website, hcet.org, also has a lot of things on it that are pretty easy to peruse. And then with that, I will turn it over to Dr. Schrader to introduce herself and get us started with our exciting content today.
So, hi, I'm Dr. Schrader. I am both a pediatrician and a child and adolescent psychiatrist. I had previously worked in primary care pediatrics, just so you know that I have that background, that I did that for a few years when I finished training. But currently, I'm working primarily in a hospital-based setting. My passion is for emergency psychiatry, so doing emergency assessments for high acuity situations in the ER or the ED, but have worked in the consult setting on the medical floors over the past year and a half. And so we're just going to talk about some things that are related to trauma-informed care in pediatrics specifically. So I have no conflicts of interest to disclose, nor any financial disclosures. For our objectives for learning in this session, I know that most of you are probably familiar with the different categories of ACEs. We're going to identify them and some of the expansion of them, as well as other forms of trauma. Review how health outcomes are related to trauma and adversity, in defining trauma-informed care in pediatrics, and then examining some strategies for using trauma-informed care approaches in pediatrics specifically and some applications of that. So we know for kids and like through development that both positive and negative experiences in childhood have significant impacts on subsequent health, mental health, and developmental trajectories. That's why we have programs for early intervention when it comes to developmental things, but we don't have that as much established as part of our infrastructure in our country for things like mental health. Um, One thing that is also important to consider, like when we think about these positive and these negative experiences shaping who kids become throughout their life, is the foundations. So, foundations of each of our homes or our houses as individuals are different. In early childhood, some children will be spending time with very solid foundations to build and develop upon, whereas some of their peers will not have that. And that building upon that then is not as stable or solid. And so, one of the activities I did for this through a training center that I thought was very interesting, I'm trying to describe it to you guys the best way I could because doing it made me feel like, oh, I understand better with this concept, even though intellectually I did. So, what we did was we got pipe cleaners, and we got so many pipe cleaners to build a foundation. So, one person, I can't remember the exact number, but you were able to build a solid square with pipe cleaners, and then you could build on top of it through this tower. But each group got different amounts of pipe cleaners to start with. And so when you were given, say you were given 12 to give a solid foundation of a square versus 4 versus 3, your foundations and building on that became very unstable when you didn't have as much of the rock solid bottom. And I think that that is something that is important to think about when we look at pediatrics because some of us have a house of cards, some of us are in little teepees, some of us are solid blocks, or like the kid in the bottom, like we've got a real solid house made out of wood and nails and it's keeping us grounded. But that's not where everyone starts. And so we have to consider that with pediatrics. Um, when we look at trauma, most children will experience some form of trauma during their childhood, and many suffer adversities. And so when we look at like what is the definition of trauma, one thing that is kind of really important to understand about trauma is that it is in the eye of the beholder. Each individual decides if a given experience is traumatic or not. Some individuals, from when we think about like mass events or even children in the same home, will experience the same event, but individual factors influence whether that is perceived to be traumatic or not. And this can also come back to our foundations. The other thing that is really interesting in being a child psychiatrist is we sometimes have to remind ourselves that the perception of what is traumatic is different for kids. So some kids will have homes where they experience emotional, physical abuse, and they might have witnessed like gun violence in their community, but they don't necessarily consider that traumatic. And part of that is their framework. Whereas you have other children who maybe are in more privileged communities where their parents going through a divorce is traumatic. And those are very different experiences, but it's based on the perception of the individual. I think there are also various different types of trauma that include like acute, chronic, complex, historical ones, intergenerational, political, community. There's lots of different types of trauma, and it just depends on the individual. Um, when we look at the original CDC Kaiser Permanente study That was one of the largest investigations into child abuse and neglect, as well as household challenges and those subsequent impacts on later in life health and well-being. This was conducted between 1995 and 1997. The study found by looking at 17,000 health maintenance organization members from Southern California that they defined these as the kind of traditional original ACEs or adverse childhood experiences that could have impacts on later health status and behavior. So, ones that we're familiar with are abuse, which is emotional, physical, sexual. You have neglect, both physical and emotional, but also these household challenges. And again, original study, we'll get into some of the expansion, but you have violence in the home, but like mom being treated violently was like an isolated one, not just violence in the home in general. Substance use, mental illness, parental separation or divorce, and then incarcerated household members. That doesn't necessarily have to be a guardian. Um, but over time, we've seen an expansion of ACEs. And these expansion of ACEs, when you look at some of the data and the different kind of perspectives that exist, there are so many expansion of ACEs now at this point. And so these were some of the ones that I kind of tried to summarize that other things were redundant. So like community violence, experiencing racism or discrimination, financial stressors, so poverty or financial strain. So it's not just living in poverty, but it's also living in a home that might be strained financially for whatever reason that might be. Growing up with limited kind of quality access to schooling or housing has impacts. For people that are not necessarily in our country experiencing these things, but they might be immigrants, witnessing or experiencing acts of terrorism or refugee or war experiences, kind of having to move from their homes and living in kind of transitional locations until they can move from that country. Medical trauma is something we have to consider as well, and that is something that I probably see more of in the hospital setting. Having caregivers with significant medical needs, natural disasters, which we've seen more in our country, separations from caregivers, which is not just like being placed in foster care, but also like things that can just require an abrupt transition of not being with your primary caregiver, and then losses of loved ones. So when you look at the numbers, the original study, based on adults and retrospective information, was that 64% had at least one ACE and 12.5% had four or more ACEs. Um, and so when we look at an additional study that was done in 2023, they found that in these high school students that they were studying, 3 out of 4 of them had at least one ACE. So those numbers are similar, but they're 75% higher than 64%. And then 1 in 5 had four or more ACEs. Still, the number is also higher. And so these are high school students reporting their experience. And this is also done more recently. And so I think we also have to take into context the expansion of ACEs, but also some of the current events and situations that children and adolescents are facing currently that maybe weren't as, I wouldn't say they weren't as prevalent when the original study was done for when those people were children. I think it's also the media, the access, the knowing, the knowledge of everything that's happening in the world through social media and news that maybe wasn't as available to people that were retrospectively answering this in the 90s. The most common ACEs that were reported in these high school students were emotional and physical abuse and living in a household affected by poor mental health or substance use, which to me, substance use is a mental health concern, so they kind of go together, but that's not everyone's perspective. And then looking at some data from the National Survey of Children's Health that was completed in 2019 to 2020, they found that 44% of Indiana youth had four or more, not sorry, not four, one or more ACEs. So when we think about early experiences, these also have influences on gene expression and long-term development. And so we all think of the genome kind of being like the hardware of our body, but the operating system is the epigenome that determines which functions of the hardware do and don't work. And this is built over time through experiences that leave a mark on our genes, whether that be temporary or permanent, turning on and off genes and what's being coded and what's not. So we know that nutritional status, exposure to certain toxin or drugs, and lived experience can do this, but also epigenetic changes can occur in pregnancy to the fetus that are passed down and can then be passed down intergenerationally, which is such a thing that I nerd out about because I'm just like, it's fascinating that this can happen and also sad that that can happen. But the epigenetic impacts on our genes during fetal and infant development have notable consequences for brain function that can last a long time, which plays that role into our foundations being different. Exposure to toxic stress during pregnancy as mothers or as young children can have this impact. And one of the things that is important to this is the toxic stress that can occur in that is in the absence of protective relationships and factors. And so when you don't have those things, it can result in these persistent epigenetic changes that impact stress responses and can contribute to prolonged stress responses. And those changes result in consequences in the brain that can resemble anxiety or depression. And so when this occurs in fetal development, it impacts organ development and can potentially impact multiple organ systems, which then has the physical impact on the health as well throughout a child's future. Um, the ACE pyramid is, and this is from CDC and the Kaiser study, it kind of represents a conceptual framework for how ACE study uncovered that ACEs are strongly related to the development of risk factors and downstream impacts. And so ACEs are like the third line up. So there are like other factors or foundations that contribute to ACEs being something that someone is exposed to. But then it disrupts your neurodevelopment, which then like causes impairment in other areas, which affects your behaviors that can increase your health risks, and then ultimately like can contribute to early death through downstream impacts. And that's how it impacts the life course of an individual. The impact of ACEs and trauma on health. And I say trauma because the original ACEs were so narrow and we've expanded kind of what they are, but they're not formally always called ACEs, and people have different perceptions of that. But it can affect kind of risk outcomes that impact behavior, such as substance use, whether that's alcohol, smoking, or other use, missing work, not engaging in physical activity that is health preventive as well. And then from a physical and mental health standpoint, it increases your metabolic effects like diabetes, obesity, but also your mental health with depression and suicide threats. And I would say more suicidality. But then with STIs, that's related to more risky health taking behaviors, and whether that's due to education about what safe sex practices are, or whether that is just high risk behaviors in general. And kind of some of these other things with heart disease, cancer, stroke, and COPD. The more ACEs a person has experienced, the more likely they are to experience negative health outcomes. And one of the things that I like about this graphic that I found from Advokids versus other graphics I found is that it listed them specifically as possible risk outcomes. Someone having ACEs or a high number of ACEs is not a guarantee for these things, but it is a possible risk. And so um, I think taking that into mind when we're working with kids, when we have some potential to change the trajectory, is also important. So I imagine most of us are familiar with the stress response of fight or flight, and most are familiar with the freeze response as well. Children don't generally do well in a fight or flight stress response, and they often use an alternative stress response called an affiliate response, where it is utilized by humans in a manner in which, when under stress, we are more likely to turn to others that can help us manage the threat. That is especially important for children who are unable to handle the fight, or freeze themselves because of their age, because of their developmental status. And so, what about when children don't have someone to turn to for help? How do they manage it? How do they navigate that? And that kind of pulls into what different types of stressors look like. And so, there are positive stressors that are temporary. They cause brief increases in stress hormones or physical symptoms like, heart rate or different things. And so this can be seen kind of in situations like exams or sports competitions or games. Like it's positive stress, it's temporary. Tolerable stress is more serious, but it's also temporary, and it is buffered and made tolerable by the presence of supportive or validating relationships. So some of that can be temporary housing displacement, um, losing a loved one if you kind of have that support to navigate the stress behind it. Toxic stressors, on the other hand, are prolonged activation of a stress response, and there is an absence of a protective or supportive relationship. And here's where the children who don't have help or support or the affiliate response, they end up kind of deferring more to these fight, flight, or freeze responses, but don't have the ability to kind of navigate that as an adult would. And so, what could be experienced as a tolerable stressor becomes a toxic stressor. And we do know that the presence of just one safe, caring adult, consistent across time, can mitigate the impact of toxic stress and kind of transition it to tolerable. So, what happens to your brain when you're faced with that level of stress every day and the body's stress responses remain activated? Um, when children and adolescents don't have that environment to support them, it impacts brain development, gene expression, and the immune system. So, prolonged and toxic stress increases or prolongs the secretion of various hormones, including like norepinephrine, serotonin, cortisol, but also GABA, endogenous opiates, and corticotropin releasing hormone that have impacts on the developing brain. So I'm going to be honest, you guys, I did a deep dive into this, and I am not a neuroscientist, and it is fascinating to me, but the neurobiology of this is far more complicated than I kind of have the qualifications to share, and it is ever evolving. And so that was really interesting me to read on it and look into it at this kind of point versus when Karen and I presented on it a few years ago. So my original understanding from 3 years ago has been overridden because there's been ongoing research and discoveries that are elucidating the complex nature of these causal mechanisms and their interplay of the experiences in life for early adversity having on learning, behavior, mental and physical well-being. But what was so fascinating to me about it is that they're kind of talking in this field a little bit about a paradigm shift of how we look at illnesses in adulthood stemming from early childhood, which we know. We know that lifestyle diseases have these impacts. They don't just happen overnight, they develop over time. But the paradigm shift that is interesting to me that they're talking about is, do we look at these more as developmental disorders that begin in early childhood because of persistent health disparities and that continue to develop? And then how can we address those by reducing and addressing the toxic stress in early childhood? And that requires a lot of buy-in from society to kind of support these additional things. But it's just kind of very interesting to think about it in terms of children's health. Some of the basics that toxic stress can do is it can lead to overactivity and hypertrophy in the amygdala, which can result in loss of neurons and neural connections in the hippocampus and the prefrontal cortex that has these impacts on other things. So when the amygdala is overstimulated, it gets increased growth, and this area is related to emotional memories and in a way is an alarm system for the body that helps mediate anxiety and fear. And when it's overactive, that's not working as well. The hippocampus has stress like kind of suppresses its neurogenesis. And so when we have elevated levels of stress hormones affecting that in the glucose transporters, it leads to atrophy and a decreased volume in the hippocampus. Um, in some of the research I was reading, there's some considerations, though, that if hippocampal volume and size at one's baseline predisposes to PTSD or other trauma related disorders versus trauma causing these. And that was kind of interesting. And I think it's like the chicken or the egg theory. Like, we're not really going to have some clarity on that for quite some time. But it could kind of indicate that a smaller size of a hippocampus could increase a risk for a trauma related disorder. And the hippocampus has a role in memory and learning. And when it's under threat, that's going to not do as well. And that impacts a child's ability to access information, their context in learning, impairs their language and their social and emotional development. And I think that there's some different thoughts about how the hippocampus in this, like it affects your declarative and your working memory, but then the implicit memory of specific threatening stimuli because of how you had to survive in these situations might be very strong. And that's a nod to kind of how these experiences shape our memory and prioritize which pathways are important in our brain. But it might take other things that are adjacent to our prior trauma or threats and misinterpret them and result in kind of some dysregulated responses. And then the prefrontal cortex is involved in executive function, which is impulse control, working memory, cognitive flexibility, but also behavioral self regulation. And we know that that doesn't develop till late teens, early adulthood fully. And so when that's under prolonged stress, it's underutilized and it impacts the prefrontal cortex's ability to inhibit the amygdala activity kind of back at the top, and thus impairs our reactions to stress and can result in lability, reactivity, and an inability to kind of cope with future stressors as well. So when you think of what is possible when kind of a child has a safe, supportive environment and how trauma can affect the brain, it it is apparent that like the need of survival comes at a cost or a lack of ability to prioritize development and resiliency skills that can kind of be seen in this mnemonic that kind of comes from the American Academy of Pediatrics. So you kind of have leading to these trauma symptoms, you have the mnemonic phrase. So you have fits, frets, and fear. Um, and then you have, sorry, I'm trying to scroll through my things, regulation difficulty, attachment problems, yelling or yawning. I'll kind of get to each of these too. So let me scroll so I can actually get to them. Um, so yelling, yawning, feeling yucky can be kind of more that they're tired, they have the kind of dysregulation with their sleep and their emotions. Educational delay is kind of what we talked about, the cognitive processing. Defeated dissociation depression can show up with kind of these different mood disorders that we sometimes see in kids. And those are kind of some of the big things that we see when we're looking at trauma symptoms. Um, but one of the things with trauma disorders is they're a very complex constellation of symptoms. PTSD is one of the longest diagnostic criteria we have in the DSM for psychiatry. And sometimes when we do assessments, like the kids meet most of the criteria, but it's hard to get a history from a child at a certain age to support all of the criteria often. So sometimes they'll get a trauma or stressor related disorder because they don't meet the full criteria of PTSD. But the other thing about trauma and PTSD in my mind is that it can be considered as the ultimate mask because it can present as so many other symptoms or psychiatric conditions and also has a lot of comorbid psychiatric diagnoses with it. I can think of various patients who initially presented with anxiety, depression, ADHD, or ODD symptoms and had had that diagnosis. But when you get down to like the underlying core etiology, it was rooted in trauma. And there's different debates of kind of how you go about that because do you still treat the anxiety and the mood disorder? Yes, you do. But you also aren't going to get as far as you would like to in treatment and prognosis for that patient until you also address the trauma. But sometimes you have to treat the symptoms that you're seeing that are mood disorders or ADHD or ODD in order to help the child get to a point where they can work through that trauma. And I think that that is a difference of opinion across different psychiatrists. But that has been my experience that you do treat the symptoms in order to support treating the core underlying etiology. Um, and so I think one of the things with kids who have trauma, who present with opposition, defiance, aggression, or agitation, this can be interpreted by even healthcare providers as willful, and that they're choosing to kind of have these behaviors. And this happens, unfortunately, more often in children of color and males, and it can contribute to certain groups of children and adolescents being more likely to be dismissed from school or have difficulties with law enforcement, when in reality they were learned behaviors through trauma reactive responses, or also considering the environment they're coming from of what might be normalized in their home or their community for conflict resolution. And so pairing that with their developmental status and where they're at, where their brain doesn't have the ability or the executive function to override the emotional reactivity that they're having to a specific situation. That all makes it very difficult. So when we shift to what trauma-informed care looks like in clinical pediatrics, there's the thing to consider is like potential activators for someone's trauma. It's not just the exposure to potential activators through interactions with the healthcare system and the care we provide, but it can also be in the presenting concern. So, for example, having the behavioral issues at school in the context of an activator might be the real issue that, like, the chief complaint for why they're coming to see you, but we just haven't uncovered what that activator is in the school setting. And like, why is it just this setting that they're having these issues? Why is it just with this teacher? What about the situation? And so it's also not just about activators for our patients, but it's also for their families and something to consider for our staff and team members as well, because we all have these histories and different kind of experiences that build us to who we are. Trauma-informed care is defined by the National Child Traumatic Stress Network as medical care in which all parties involved assess, recognize, and respond to the effects of trauma on children, their caregivers, and other healthcare providers. And so this also includes being mindful of secondary traumatic stress with the emotional impact that one experiences by hearing or being privileged to be that person for our patients when we hear trauma firsthand. And I know that in psychiatry, we have a unique experience of that. But I also think in pediatrics, a lot of kids are more comfortable with their pediatric providers sharing that because they have a long-standing relationship and rapport. And so considering that as part of our trauma-informed care is also considering ourselves and our colleagues. Um, Trauma-informed care should be implemented in a kind of a universal precautions model where it is applied to everyone and integrated as part of practice. And we should operate under a construct that trauma presents uniquely for everyone and everyone has different distinct experiences. And I kind of struggle because I like don't want to say that we should assume everyone has trauma because that can contribute to bias as well. But we do know with the data that the majority of people have experienced some adversity and trauma or traumatic experiences, but whether they perceive that or not is different. Um, we're also never owed a disclosure. And I think that that is tough sometimes, depending on your line of work, that it can sometimes be detrimental to pressure or try and get information from a child about a trauma because it could impact their long-term healing in traumatic treatment or trauma treatment, I guess. And so that's sometimes difficult. Like in my line of work, we're sometimes asked to assess for abuse, asked to assess for these things. I'm like, that's not my role. Like I'm meeting this kid one time to do a psychiatric assessment in the context of a chronic illness. And I am not going to pressure the child to disclose a longstanding history of abuse because I'm going to have such a brief interaction in their life that if they disclose it to me, great, but I am not going to try and pull it out of them. And I think that sometimes it's hard to remember that because it is imperative, it's important information. We want our kids to be safe, but we also don't want to do it in a way that is potentially harmful. Give me all this trust, share this really hard stuff that you've been through and then I'm never going to be a part of your life again. And that is something that we really have to consider when we're obtaining this information too. Um, when we think about kind of the four key elements of trauma-informed care, we consider kind of the widespread effects of trauma and the potential paths. So realizing that trauma is pretty widespread, recognizing the signs and symptoms of trauma around us and that its potential impact on patients, family, staff, but also organizations, systems, our society. Responding by applying the knowledge we have by advocating for policies, procedures, or practices that acknowledge that. And I think the other thing that sometimes gets missed is sometimes when these formal things don't exist, if we see something that makes us uncomfortable, saying something about it, be like, hey, let's take a step back. So like for instance, um, say we have a highly agitated patient in the hospital and they've required multiple 4-point restraints. If I go into a room and they're calm, cooperative, I'm like, let's get those restraints off that bed because that's not setting this patient up for a trauma-informed care approach. That is threatening the use of restraints, which is uncomfortable. That's not fair to the patient. Like they are calm and cooperative now. Like let's get them off and get them out. And so I think like sometimes like saying those things or asking like, hey, can we readjust given the current situation? And that's another way to respond. And then that can also play a role into resisting re-traumatization, kind of in a clinical setting, and what we can do from that. And then some of the key principles in trauma-informed care from SAMHSA are safety, trustworthiness, and transparency, peer support for your colleagues and for each other, collaboration of mutuality, being kind of empowered and having a voice and a choice for our patients and giving them options, and then considering kind of the cultural, historical, and gender issues that play into this as well. So, children do have inherent risks at birth that include their available social supports, in utero brain development, but intergenerational trauma as well, like we had talked about. So, when we think about trauma-informed care in pediatrics, the parent-child or the guardian-child relationship is at the center of our care. When we think of sensitive or mindful care, it's much broader than just the child. It's also important to think about the guardian's own experience and kind of a broader context of that. So some familial factors to consider and at times discuss if appropriate is like how was the guardian raised? How is that upbringing influencing the current raising of this child? Is there intergenerational trauma? And when you think of kind of a broader a psychosocial context, what are the stressors? Are they facing social determinants of health? Do they have social expectations? And like some of the things I can think about that is some families who might have a child with neurodevelopmental delays or autism, and the one of the partners or one of the guardians leaves the home because they're not willing to help raise this child, or the family does, the mom or the dad that is solely raising the child doesn't have support from the family because they don't want to be involved in the care of the child because of behavioral issues. That is also important to consider. Immigration status, what are the supports for the patient and the family beyond the nuclear family? Gender identity and expression, as well as sexual orientation, are things that can be stressors kind of in this broader psychosocial context to consider. And then, like we mentioned, the presence of one supportive continuous relationship for a child throughout their life. Um, when we think of kind of surveillance and looking at things, considering kind of broad, open-ended questions is helpful. So like one of the ways that I ask it when I'm doing a trauma assessment, I was like, anything really big, bad, scary, or upsetting happen in your life that bothers you? And I kind of just open with that, and then you can go from questions from there, or anything that you would consider traumatic. Um, and then asking like any changes in the home or anyone coming or going from the home lately can be helpful too. Um, Validating both the patient and the caregiver for their situations and kind of just making sure that they feel comfortable to share things as much as we can. And then reassuring them, communicating that they're safe verbally and non-verbally here. Routines after traumatic experience are very important for all of us, but children really thrive in that and having those expectations and those consistency. And so that can be part of like bedtime and morning rituals, cultural practices, but also how do we have routines of praise for more simple things like them following instructions or completing tasks in those times. And then for regulation, helping them learn how to practice naming their feelings and emotions, identify what they're experiencing, how or what is helpful for them to calm their mind and body when they are feeling overwhelmed or stressed. And having kind of big emotions is some of the things that requires, we know this, modeling. And so sometimes we have to be explicit about talking about that with guardians too. And I think one of the things that not all parents or guardians are fully aware of is that kids, we know this, they learn most from watching around them. And so I think when parents aren't able to navigate stress themselves, that models that for their child. And so kind of helping the guardian learn how to do that themselves or giving tips or resources can be helpful for helping educate the children on how to do that too. Um, so one thing in kind of trauma-informed care with pediatrics is including, once they're old enough, assenting to a process, adolescent, offering them choices, but also not offering false choices. And so I think that is challenging because when you say like, do you want this? And they want to play their video game, right? And so like you don't say something that they can do that they can't do. So you have to do your room first and then you can play your video game. Do you want to take out the trash or do you want to clean your room first? Like offering them choices and agency where you can, but not offering them ones that truly can't be a choice. Communicating with them before doing things. So for younger kids, that's telling them about, if they're old enough to understand, like telling them about getting their labs or their shots before you just come in and do it. In the hospital or medical settings, like utilizing additional supports such as child life or whatever you may have in your clinic settings. Allowing kids to take breaks because sometimes they just need a chance to process what is happening, and that can be incredibly helpful. And sometimes I find that I tell, like, when we come back to offering choices, that a kid will be very dysregulated. I'm like, hey, do you want a break now? Like, we have to talk. We have to work through this. Do you want me to stay and we do this now? Or would you like a break and I come back in 20 minutes? And that gives them some autonomy and the ability to make a choice. And most often they want you to come back. But sometimes when they realize, like, I'm not getting out of this, they choose to kind of just progress and get it done with. I think that kind of plays a role in like what alternative approaches can we have to kind of provide the care to the children that we need to, but still taking some considerations for what that individual child needs. And then just kind of being mindful about our own attitudes. Like, because sometimes when you're really busy and you've got a time constraint, like you're trying to get things done. And ultimately, probably having some of that resistance is going to make it take longer than it would have. But then having kind of that open dialogue about expectations and boundaries too. Um, so I have some clinical examples for us to kind of talk about. So we have a disruptive, high-risk taking adolescent who came into the hospital. 16-year-old brought in by police in handcuffs. The police paperwork has a chief complaint of bipolar disorder. The medical chief complaint when they arrive to the emergency room is aggression and agitation. They're escalated, they're yelling, and they're having a lot of aggression. And they communicate clearly a desire for certain team members to leave the room. So most of these are cases that I've actually been involved with. And I think the initial approach in this situation was we have an agitated patient in a children's ER who is an older adolescent. We have young children around. The kind of initial approach is how do we de-escalate? But that was not happening with verbal or other de-escalation strategies. So it initially escalated to a point of using restraints and considering the use of PRNs. Now, when we come at that from a trauma-informed perspective, sometimes you do have to escalate to that level of care. But let's circle back to the fact that the patient communicated a clear desire for certain team members to leave the room. That was male team members, and that was any team member that was not a person of color. If we respected that, what would happen? And so when I kind of became involved in this, the patient was in 4-point restraints with multiple team members in the room. The patient was consistently communicating this. And so I said, let's get everyone out. Let's follow like what she wants. And she de-escalated. She was calm. She only needed one person in the room with her. And she was able to kind of have a moment to de-escalate on her own and feel that she was in a safe place. So if we take some of the context back behind this, This is a young adolescent female who was not new to encounters with law enforcement, but the law enforcement that brought her in were all white males who had required, due to the nature of, requires a choice of word that was communicated to me, not necessarily my personal opinion, that in the field, when they arrived to the location that they were called to, it required some physical hands-on intervention by police. This is a child who is likely terrified, given, various contexts in our culture, but also is being labeled as having bipolar disorder. This patient has no history of bipolar disorder. When I ask about what's contributing to you guys, like where is this diagnosis coming from in your paperwork, like why is this what's going on, and they're like, well, do you see her? And I'm like, she's agitated, that doesn't indicate bipolar disorder. And so I think from a trauma-informed care perspective, once they transitioned from law enforcement to healthcare, we had a responsibility to find a way that we could safely manage and have a trauma-informed care perspective. And luckily, in this situation, we were able to remove the individuals that the patient was asking to leave the room. And it did de-escalate and didn't require further intervention, which I think allowed us to transition from a non-trauma informed care perspective in the law enforcement hand to a trauma informed care perspective in ours. But the first transition period did not go as well as we would have preferred it to. Um, we have a 14-year-old with autism spectrum disorder and ID who has a chronic history of aggression and agitation, presenting for severe injuries secondary to self-injurious behavior. And they need medical care because they need debridement of wounds. So one of their self-injurious behaviors was they had a habit of biting the skin off of their hands, resulting in kind of significant infections. And they had had multiple return ED visits. And so when we get to this ED visit, the patient refuses to get out of the car and becomes aggressive with staff. And so I think in this situation, you have additional challenges from a trauma-informed care perspective is how much is the child, like if you're preparing them and you're giving them forewarning, how much do they kind of truly comprehend and understand versus when you show up to the ED, they know that this doesn't usually go well, it involves pain. How do we navigate that? And so, when we thought about kind of future visits, because this was a chronic kind of concern that required multiple ED visits over time, we did consider the use of kind of PRN medications in terms of treatment of anxiety, not for agitation and aggression. And it was pre-treatment with things such as hydroxyzine, not escalating to the level of antipsychotics or benzos or intramuscular medications. The other thing that was incredibly helpful was having multiple staff that he was comfortable with and he did know who went with him to the ED and stayed with him throughout the ED visit. Because that provided a sense of safety for him. The other thing is he really just loved having soda drinks, and we weren't normally giving him soda drinks where he was at because there were metabolic effects that we were worried about. But in this situation, we found that this was helpful and could help mitigate some escalation. And so sometimes it's understanding and being creative outside of the box against what would be your traditional care to try and figure out how do we handle this in the most to prevent re-traumatization. How do we navigate this in a way that is successful for the child, but also for the team members? Because when he did get aggressive and agitated, he was not a small child. And so it did result in significant property destruction. And so, how do we kind of approach this in a different, like a multi-pronged approach for this child? And those did go better. Um, you have a child in foster care with a known history of trauma. It's a 5-year-old patient who presents with foster parents as a kinship placement with concerns for disruptive behaviors. They're currently in their 6th foster home in the past 2 years. They're having changes in placements due to their disruptive behavior, and the foster parents are considering whether they can continue to care for this child. Um, I don't know if a lot of you guys have experience with these type of situations, but I think one of the things that we kind of took a step back from attempting to have a trauma-informed care perspective was going back to that integral guardian-child relationship and asked kind of the foster parents, like, what were their expectations of this 5-year-old with this history? What had they been educated or prepared for before they had this child in their home? I think the other challenging thing was that this child was a sibling and they were considering whether they were going to continue to care for this child or have him rehomed while keeping siblings who happened to be older. And I think the other thing that is very challenging with DCS in kids in foster care is we don't always know their trauma history before they're placed with a family. And sometimes it's not known, period. Sometimes DCS is not as effective about communicating that with foster families. And so focusing on the guardian child relationship was how we were able to kind of navigate what is best for this child and kind of set up some expectations. And so we did ultimately see this child multiple times in the emergency room for disruptive behaviors, but the disruptive behaviors were declining in severity over time. Part of that was due to kind of interventions that were incorporated. Essentially, we did like parent management training. So it was about the parent and the child. And so that was the trauma-informed perspective for this specific situation. But I think when you have kids kind of in this dynamic of foster care or temporary housing placement with other families, because I know like Families First also does emergency shelter, that managing or helping the families that are guardians that are providing care to these children, managing their expectations so that they can be better prepared for this child, but also for future children, so that we don't have multiple failed foster placements because that also has negative impacts on a child. And then we have a 17-year-old with new onset psychosis. They have a lot of mood lability, new onset aggression. They were placed in a restraint chair with chemical restraints early in their presentation. And the patient had caused significant property destruction, and staff morale was not good. Substance-induced psychosis, quite challenging for treatment because sometimes it's about metabolizing the substance and that takes time. And so, considering how to safely navigate care for a patient that is substantially agitated, but also coming at it with a trauma-informed care perspective, it can be very challenging when you are in settings where the fatigue around this is high because there is a staff and patient safety issue, and that's not to be negated. Um, but I think when you come at it from a patient perspective and trying to be trauma-informed care, you have to start once they're calm and cooperative, you have to restart the clock and act as if it didn't happen and kind of check your own bias. Be smart and be prepared, but like don't have the restraint sitting on the bed waiting for the patient. Don't treat them as if you're scared of them because that often can kind of escalate the situation. So some of the things that we do kind of talk about in psychiatry, which I'm sure most of you are aware of, is like if you're seeing this patient, keep yourself between the exit and the patient. Don't let the patient get between you and the exit. And that's a way that you can manage your own safety. It's removing items in the room that could be used for self-harm or harm to others. So cords, things that can be thrown, making sure the cabinets and the drawers are locked or zip tied so that they can't be opened. Having your plans for if you do need to use chemical restraints, having that available and ordered so that that's not a barrier if safety really does become a concern. Um, and then making sure, like, when the patient is clear, that you still are communicating with them as if they fully understand. I think sometimes when we have patients who are psychotic, it is hard to have a reasonable conversation because of the influence of disorganization and psychosis that is occurring. But when you don't, that sometimes can result in escalation as well. And so sometimes keeping interactions more brief, but still kind of appropriate for their developmental status based on their chronological age, and then tweaking that based on their current clinical status too. So with this kind of case, one of the things is that we do have the privilege and honor to be healthcare providers and to witness some of the scariest or hardest moments that our patients experience in their lives, and to hear some incredibly and very hard narratives that they share with us. But we have the opportunity to be that support and an anchor for them in these moments of extreme vulnerability. That sometimes we are the only people that they ever share some of these experiences with. And that is awesome. That is also a lot of responsibility and it's a lot of weight at times. And so it's important to not forget about you, to not forget about us as colleagues for each other, because we do carry our own histories, our own traumas, things that kind of occur adjacent to patient experiences or adjacent to our jobs. And that can come through secondary trauma, vicarious trauma, second victims, or moral injury. And compassion fatigue and burnout are these things too, but often are secondary to these other things. And so I think it's important to not forget about yourselves and your colleagues in this process of the work that we do in healthcare. So, we get lots of lectures on how to take care of ourselves and how do we do that. I think some things are really basic self-awareness is, am I aware of how the different aspects of my job can be activating to me? And why is that based on my own experiences? Where can or does my own history or bias present in ways that I think or interact with patients, families, or colleagues? Do I understand where that's rooted in? And sometimes that self-awareness helps us redirect too. And how can I take care of myself so I can continue to give to my job, but also to my families, my own family, our colleagues. And so how do we kind of figure those things out for ourselves? When it comes to culture and my kind of personal perspectives, it's hard to impact things on a system level because that takes time and that's large and that's institutional and organizational. But in my own small team that I work with day to day, I can have an impact on the culture there. So, how can I be more mindful and foster a culture that promotes wellness, open dialogues, and support in our own work communities? How can we adjust our dialogue to center around empathy and compassion for patients? How do we proactively support each other and mitigate the risks of burnout, compassion fatigue, or moral injury in our own jobs? And I think, like, from an institution level, there's different things that people can do. So, like, sometimes that's having a peer support network, or that's having something like compassion rounds where you talk about these hard experiences and things that were rewarding from them, but also having like brief debriefing sessions after atypical patients that are not maybe part of our normal debriefing sessions, but how do we do that to talk about like what was hard or what we feel like was a success in that situation? And I think even from a culture perspective, especially with like new hires and younger trainees coming in, sometimes redirecting like, hey, yes, I see what you're saying, but like, let's also talk about maybe that's not what it is. So I think sometimes with kids, they will get labeled as being manipulative. And I'm like, or they're just being really creative in the ways to get their needs and wants met. I don't think it's manipulative at this age. I think they're just learning how to get their needs and wants met. And so I think reframing that or kind of calling it out when it is occurring and reframing it to be more kind of compassionate or have more empathy to that can help foster a culture of that perspective in your own teams. We know this topic matter can be very heavy and can feel at times very dark, given the actual facts and the prevalence of trauma. But there are some things to kind of leave you on a more positive note and maybe with some hope. So we talked about the presence of a safe, stable, nurturing relationship and environment can have profound impacts on mitigating the risk of ACEs. On a caregiver role that involves talking to children about mental health and emotions, teaching them to recognize and manage them, and looking for opportunities to praise them and build their self-esteem. So supporting them in that, but also supporting their education. In a community that includes like supporting those around us, advocating for policies that support good education, nutrition, housing, that support balance of guardians working and having family lives. That includes supporting colleagues that might have those kind of life needs at this stage. And also kind of childcare, which is an issue in our country with the cost of childcare, but how do we find ways to support and advocate for that? Some community examples in action that we kind of are familiar with in our state is Early Head Start. The Incredible Years is another one. And then Safe Care is an organization that kind of helps with kind of safety around pediatric patients. Um, Protective factors include kind of those safe communities. Connection is one, both within the community, but also for kids, friendships, but for the family, it's like feeling connected to a community in where you're living, which is sometimes hard, especially for immigrant families. Um, Quality education, access to medical care, we know is important. And then effective conflict management being modeled as well. In a safe and stable, nurturing environment, the resilient skills a child can develop can be quite profound and can help them adapt to adversity. And so, some of those skills that they learned include this mnemonic called threads. So, thinking and learning brain, they have protection, they have the safety to allow them to explore and learn. You think about that in early child development, where a young kid will like come to their primary caregiver or guardian, touch base, and then they'll go back out and explore. And so that's kind of what we're seeing here. But think about that for older children as well. Hope for a different future, regulation and self-control. When an adult models this and helps a child co-regulate, it provides a sense of security for them. Efficacy, like gaining or feeling that they have a sense of control over their environment, is important. And this is also plays a role in the development of mental health concerns later in life. So, individuals that feel that they have an internal locus of control where they feel like they can have control over their environment or circumstances, or they can have an impact on it that can change it, that is a protective factor for the development of mental health concerns in adolescence. Whereas kids who have an external locus of control, where they don't feel like they have the ability to impact what is happening to them and that they just are existing in the world happens to them, that is a risk factor for developing mental health concerns. So this one is a particularly important one. Attachment, we know that secure attachment is the ideal. It provides a sense of self in relation to others, and it can kind of create that safe space. And then developmental skills and mastery for age appropriate tasks is another one. And then, like we talked about in the last one, social connection is very important. The ability to develop these skills occurs in the context of a give and take over time, and that's where a continuous relationship is important because it supports them through time, through that childhood. And so these are references from that. And then I had any questions or thoughts that anyone has.
Thank you so much, Dr. Schrader. Yeah, we'll give a couple minutes. If people have questions, I'll let them roll in. Let me check the Q&A. I don't see any right now, but y'all please feel free to put them in.
I
Um,
I had one I could throw out.
yeah, please.
So I love, sorry, you're getting my part cat here. I love the way that you talk about affiliate. And, a lot of people also talk about fawn as kind of an extra F. And I was wondering if you could sort of differentiate fawn and affiliate. Is that just like cute 4F language versus affiliate? Is that an adult versus child response? Can you talk about that a little bit?
I don't know that I'm as familiar with fawn, so I don't know if I could because I just am not as familiar with that. So maybe it is a pediatric versus adult one, but
Okay. Yeah, I actually think that makes sense because I think, people talk about fawn as kind of connect and like reflect what that person needs to hear. So I think we think about it as like especially in like less healthy relationships, how are people responding to a threat maybe from an outside person by like burying their own needs by affiliating with someone else or by kind of connecting to someone else in that way. Um, and yeah, we don't talk about affiliate as much for adults. So I was just like, that's so neat, and maybe that's the next thing we should look into together.
yeah, I'll have to look at that because that'd be interesting.
Cool, cool.
I have a quick question. I'm so sorry if this is obvious to everyone else. What is moral injury? I saw that on one of your slides.
Very complex, I think, to answer. So, I think my answer might not be someone else's answer because I think there's probably a formal definition that I'm not going to pull into my mind right at this moment. But I think one of the things with moral injury is in healthcare, when you know what you need to do in what is right, what is moral, but you are unable to do it because of barriers that exist, whether by law for the states that you practice in or whether by barriers of insurance payment. It can be in a very challenging aspect of practice in healthcare to know what is morally and ethically right, but to be unable to do that. And that causes moral injury to the healthcare providers because it goes against their ethics and like the code that the Hippocratic oath that we have vowed to. And
Yeah.
so it just can be very demoralizing.
Okay. That makes sense. I can picture a lot of examples. Okay. That
Yeah.
makes sense.
That's really really well described. The other way that I hear it talked about is when you have two deeply held beliefs that are in conflict. So, I sort of a lot of this conversation came out around COVID, and a sort of quintessential example there could be if one deeply held belief is I show up at work every day to take the best care of my patients possible. That's why I do this job. I also have a deeply held belief that that it's my role and priority to keep my family and loved ones safe. And during COVID, those were irreconcilable. And so again, it's that circumstances make it so I can't live within my moral code for one reason or another.
Yeah, that's really, oh my gosh, that's so huge. You're right. That is hard to describe, like both of those. Actually, Dr. Schrader, would you mind clicking to the next slide? We'll
Yeah.
still, like, if anyone has questions, like, please pop them in or in the chat or Q&A. This is, so if you want to get in contact with us, get on our MTITC mailing list. Kara's information is right there. And you can sign up to be on our list. You can just put in the subject MTITC or something and email updates at hcet.org. And then Kara's always happy to field questions. I think one thing we're looking at now is if you think you want a certain training or a certain topic that your organization would like, we're always happy to hear your ideas. And that actually brings me to next slide, please. We would love to hear from you. What did you think about, the discussion here today? What other things would you like to learn about? Please share your thoughts with us. We use these evaluations really to plan future opportunities for learning and to improve ourselves. So we're super happy that you all could join us today. If anyone has any questions or comments, please feel free. Um, and I'll give, Kara and Dr. Schrader a chance too if there's anything else you want to say before I let us all go.
Well, I had one last that I loved learning from you today that I appreciated this point because it showcases how trauma informed care and creating a trauma informed environment really is situational and unique, and it's part of why it's challenging, right? That we can't just say like here's your checklist and now we move through. And that's because I love that you gave the example of a trauma informed approach around safety is a situation where maybe the provider needs to stand between the patient and the door, because often in these lectures, like I think just last week I gave that the exact opposite as an example, right? That in a not escalated circumstance, a good trauma informed principle is to make sure that you're not between the patient and the door so that they know they have an exit. But it's such a good point that when we talk about safety as a core principle, it is both for the people we serve and for staff themselves. And so you have to use that judgment in that moment of which one matters, right? And they're both in opposition and in concert. So I loved that you brought that up today. So thanks.
I no problem. I think the additional thing to that maybe not all fields of medicine have to interact with like psychiatry does is in those situations I feel like it is my responsibility to set the patient up for success. So if they're agitated or they're psychotic, like anything that I do could potentially contribute to agitation, which leads to escalation that really leads to restraints, leads to the use of chemical restraints. And what can I do that avoids that? And so sometimes that is, I'm going to stand at the door so that if you need a break, I can leave, or whatever it may be. Like, how do I set you up for success given this unique situation, which does limit my ability to do my job thoroughly in a formal, like, documentation standpoint, but it allows me to do my job correctly to support you from a trauma-informed care perspective. And I think sometimes it's that give and take. It's like, do I really need that one piece of information to keep pushing them? Or do I just move forward and say, this is not constructive or helpful for the patient as a whole, and I'm just gonna not get that today?
It's a little bit of like a harm reduction model, right? Like we're going to live in the
Mhm.
reality
Yes.
of our situations. We're going to
Yeah.
do the best we can. It may not be perfect, but we're going to do the best we
Yeah.
can for ourselves, for our patients, and all the things.
Yeah.
Absolutely. Yeah, thank you so much for being here. We really appreciate your
No
time.
problem.
I learned a ton even as a parent, right? Like I'm not a healthcare practitioner by any means, but it just highlights how important, we can be as caregivers and other, important adults in the lives of the young people around us. So I really, really appreciate your time. Everyone, thanks in advance for filling out evals, and we hope you keep in touch with us, and we will talk to you soon. I'll let us go give about 4 minutes back into our day. Thank you so much.
Thanks for having me.
Thank
Yes,
you,
thank
everyone.
you.